بسم الله الرحمن الرحيم. أنا سعيد جدا إن أنا أكون موجود معاكم النهاردة في مستشفى الشيخ زايد ومع أخويا دكتور أحمد عبد الهادي وليدرز أكاديمي، ويعني أنا ببقى سعيد جدا وأنا موجود معاكم. As in GI session, we cannot pass the GI session without talking about the Jean premiere of GI malignancies in Egypt, which is the 𝐏𝐶𝐶. Here we can go to understand what we are really facing and how can we tailor the available therapeutics into the platform, the strategic platform of hepatocellular carcinoma management. Here by my disclosures and nothing to disclose for this presentation. And as you all know, liver is quite critical organ in the body, and 𝐏𝐶𝐶 also, it's a challenging disease because usually the early detection to detect an early phase of the disease is quite difficult. It is not there, and we have definitely over decades of practice that we don't have really a drug efficient in controlling the disease, as well as for the evolving resistance to the available therapeutics, even following initial response if it's there. Again, we have a high recurrence rate, even we are treating patients with the intent of cure, for resection, for ablation, for anything. Usually we will have a high recurrence rate. In addition to the variability of the tumor behavior, we do have heterogeneity within the single tumor. All of them make your disease is to have a poor prognostic outcome. So we need to understand why this is there, why we do have poor prognosis for the majority of the patients. It's correlated with the critical scenario of the liver functions, the pathophysiology of the liver disease. The liver is the main filter of the body. It's entailing with a lot of the pivotal metabolic processes, and it is responsible for clearance of a lot of invading events as viral and toxins. And the major unit, which is the hepatic lobule, constituted of central venule, portal venule, and between them different types of hepatocytes. When we have an acute insult, as seen with the viral hepatitis, for example, viral A hepatitis, for example, the conventional hepatocytes arranged around the central lobule are going to proliferate to compensate for the losses of the hepatocytes. And when we are shifting to more sustained event, like what we see with chronic hepatitis, with virus C hepatitis, it's a long-lasting process. With metabolic syndromes like the NASH, like diabetes, fatty infiltration of the liver, here we have a continuous insult on the hepatic lobule. Here, the conventional hepatocytes in blue are going to be exhausted. And we started to have a share in the process of repair by the hybrid hepatocytes arranged around the portal venule. Step by step, progressing in the process of damage and the repair, we started to have a share of other two types of cells, the ductal cells and the what we call the liver progenitor cells. And this process of repair is characterized by extensive fibrosis constraining on the portal venule. So we will start to have the newly formed hepatic tissues, the nodules, the cirrhotic nodules, and due to the fibrosis around the portal venule, we started to face the portal hypertension, which is a very early process in the regeneration of the liver following virus C hepatitis, and finally to have the 𝐏𝐶𝐶. So we do expect to have compromised functions from the process of cirrhosis, to have varices and the bleeding disorders from fibrosis around the portal venules due to the share of the repair by the hybrid hepatocytes, as well for the ductal cells and the fibrotic process, and finally the 𝐏𝐶𝐶, which is a fatal disease. So this what we are expecting to see while having a patient with cirrhotic liver and then 𝐻CC. We have to remember that 𝐻CC, it is not the major issue leading to compromised liver functions, pushing your patient to proceed for liver cell failure, but it is a byproduct of the cirrhotic events that we are facing following 𝐻CC, following HCV infection and the process of repair. Looking to the platform of the advanced hepatocellular carcinoma before the year 2007, before the sorafenib era, actually the survival outcome was quite compromised. 8 to 10 weeks, we don't have any impressive outcome for the chemotherapy, whether mono or combined modalities. Then, following the era of the TKI, following the identifying that the liver is an angiogenic organ, we started the story by 2008, following the SHARP trial for the sorafenib, and instead of having median survival outcome of weeks, we have 10 months for the first time. Then we had several TKIs approved for the management of the HCC as lenvatinib, being non-inferior, but to my mind I think it's superior to sorafenib in the outcome. And having survival progress, we started to talk about the second line treatment for regorafenib as a second line following progression on sorafenib, and cabozantinib and ramucirumab for patients with alpha-fetoprotein more than 400, and so we started to have some survival improvements, but not impressive. By the year 2018, we started to live in the immunogenic era. We have the nivolumab, pembrolizumab as a second line following failure of first line sorafenib, and we started to have more and more protraction till we got the impression of having the combined approach, whether to combine immunotherapy plus anti-angiogenic agent, because liver is an immune tolerant organ. We have to remember this. We do have exhaustion of the active T lymphocytes because we have a long-lasting duration of virus C hepatitis, and the process, the inflammatory process, is continuous exhausting the T lymphocytes. So you have the weapons, but you don't have the soldiers to fight. So we need something to render again the liver to be somewhat immune responsive through combination with anti-angiogenic agents, mainly the bevacizumab, for the competing with the vascular endothelial growth factor 1 or A, and to augment the immune scenario more and more through combining two immune therapies with durvalumab in the Himalaya trial. What we have at glance for all, when we look to the overall survival outcome, definitely atezolizumab 19 months median overall survival for the intended to treat population, and it's improving more and more for patients with low risk disease, as what we are going to see. For the progression free survival, actually we have many key players now that you can go without feeling that you are doing something that's not properly good for your patients. You have the lenvatinib progression-free survival 7.4 months. Atezolizumab, it's a little bit lower or the same, 6.8. And for the 𝐏𝐞𝐬𝐭 trial for atezo plus cabozantinib, which is another TKI, and we have the 6.8 months as a median overall survival. But what's really more impressive, that we know that we are not going to cure our patient. We need to stabilize, we need to achieve perfect disease control, and the overall response again here, as you see, the highest with atezolizumab followed by durvalumab, which is comparable to the lenvatinib. For disease control, as I have just mentioned, definitely you have many options to stabilize your patient: lenvatinib, atezolizumab, and atezocabozantinib. It's a little bit lower for the Himalaya, for the durvalumab. So you have many options to be administered to the patient as a first line treatment, depending on what you are thinking to achieve. This publication in 2024 on behalf of the American Society of Oncology, it provides a high quality evidence that atezolizumab will be associated with unprecedented improvement of the overall and progression-free survival as compared to sorafenib as a cornerstone. I do believe that sorafenib is not anymore the drug of choice for patients with HCC. Yes, it's there in the guidelines, it's available, and we have many of the generics of the sorafenib available, but I am looking for the outcome. Lenvatinib, I am one of the big fans for the lenvatinib for patients with HCC, and I do have in my own series, I have patients now exceeding 3 years and more survival outcome while being on and off on lenvatinib. And at the same time, we have a moderate level of evidence or strength of evidence that atezo-beva will not add much to the adverse events when compared to sorafenib, except for the bleeding tendency and verses. But what's really should be focused on when we go to the subgroup analysis in the IMBRAVE 150 for atezo-beva versus sorafenib in the management of advanced HCC, look here. Whether you have a macrovascular invasion, لا مؤاخذة مش ده واحد حبيبي دخل بس, macrovascular involvement, the benefit is there when we give atezo-beva. And for patients with virus C hepatitis constituting the majority of our patients in Egypt, usually it's following virus C, although the virus C is eradicated almost in among our population, but the benefit, look to the hazard ratio, it's 0.43 for patients with HCC on top of cirrhosis due to HCV infection. 0.43, remember this. And whether your patient is considered as a high risk or low risk, the benefit is there, and we can define the high risk patients as having VB4, thrombosis of the major portal vein, tumor involving more than 50% of the liver parenchyma, and bile duct invasion. I think the 3 points are the worst to be encountered amongst patients with HCV. Whether you have a high risk or non-high risk patients, atezo-beva was superior over sorafenib. Definitely it's better with patients with no high risk, but the positivity is there, and we achieved the hazard ratio of 0.68 for patients with non-high risk factors and 0.62. Still you can save more than 1/3 of your patients when you treat with atezo-beva as compared to sorafenib. Similar data coming for the progression-free survival. What about for the Himalaya? The same publication critically analyzing the outcome of the Himalaya and IMBRAVE trials, that we do have only strong level of evidence that durvalumab is superior to sorafenib in improving the overall survival, but the level of trust, the level of significance got lower when we consider the progression-free survival as well as the complications for having more than adverse events score 3 or grade 3 for patients treated with immunotherapy. What about for durva as a monotherapy? Yes, we have definitely a very good evidence that durva is not inferior to sorafenib, but definitely for myself, but aside from the financial toxicity, definitely durva is associated with better profile of adverse events as compared to sorafenib. But a critical point that when we look to the subgroup analysis, look to patients with HCC on top of HCV, it is not significant. So tell me, if you have a patient with HCV, the history of disease, HCC then on top of liver cirrhosis, are you somewhat enthusiastic to proceed for durvalumab or to depend on the Himalaya results to treat your patient? I think not. Maybe it's more precious when we consider virus B or metabolic syndromes leading to fatty infiltration of the liver as NASH or others. So when you consider the first line, by guidelines, by survival outcome, overall survival outcome, you have the leisure to go for atezolizumab or durvalumab, but with some points of constraints based on what we have from the subgroup analysis in the Himalaya trial. And if you have a contraindication to proceed for the first line immunotherapy, or living in an area with no access to immunotherapy, or we don't have enough funds for this, definitely lenvatinib, then sorafenib could be considered as the choice. Remember the HCV history and the risky patients, because HCC on top of HCV induced the cirrhosis was not positive in the Himalaya, and the Himalaya also excluded the risky patients from the subgroup, from the patients included in the trial. And again, critical appraisal by the American Society of Oncology published in 2023 that when we analyze carefully patients included in the Himalaya or the IMbrave 150, you will find that the complete responses were fewer in the Himalaya protocol as compared to the IMbrave 150, and upon the first assessment of the response, nearly double figures of the patients achieved the disease progression, 40% versus 20% in the IMbrave. So we can ask the question frankly, that if you have a patient with high tumor burden and you judge that you need to downsize or somewhat alleviation of this high tumor burden, where to go? To go for the Himalaya protocol or the IMbrave 150, keeping in mind that nothing without expenses, and we do have significant rates of the adverse events. For sorafenib, we have a long list. For myself, I don't like the adverse events associated with sorafenib, mainly for compromising the liver profile. For atezolizumab, definitely you need to have an endoscopy first. You have to look for the hypertension, proteinuria, while for the Himalaya trial, for durvalumab, the STRIDE protocol, you will find that nearly it's doubling the numbers of patients withdrawn due to immune-related adverse events. This is very important because we are using dual immune therapies. What about the bleeding risk, which is the Dr. Jekyll or the Mr. Hyde, the scenario you are facing, the threat of having bleeding varices or not? When you go to the any grade, definitely atezolizumab is associated with higher probability of having bleeding episodes, but not for more than grade 3 adverse event as bleeding. And this could be focused not for all patients. Those with higher BMI, albumin, bilirubin grade 3, and macrovascular invasion, you need to focus on the probability of having bleeding episodes, and this can be alleviated when we have a pre-treatment endoscopy and the effective ligation of the possibly threatening variceal bands. What about what we have as new arrivals to the guidelines? We all depend on the Barcelona clinic staging system for liver cancers, and for early we talk about surgery or ablation. For those with intermediate stage B, usually we depend on the local ablative measures, and the systemic treatments are somewhat delayed for more advanced disease. Look here for the new arrivals to the staging system and the management, where we have extension for patients indicated to have transplant. We have more extension of the Milan criteria, and the patients with preserved liver functions, and considering the size of the lesion and alpha-fetoprotein. And we started to constrain our approach to patients where you ensure that you have adequate portal flow and the super selectivity of the lesion to be amenable for effective TACE, while for patients with diffuse affection, infiltrative lesions, bilobar affection of the liver, here we might consider initially systemic treatment depending on the role of out of 7 lesions. And we have now 3 categories of patients with intermediate stage: those unlikely to respond to this, those with diffuse affection of the liver, and this is a common one amongst our patients, and those who likely to develop TACE associated failure based on the 7+1 criteria. We have many lesions, so you cannot ablate all, and whenever you are going to ablate, you are going to achieve some compromising of the liver function, so take care of those. And patients likely to have or to develop more worsening of the liver profile from stage B to C, for example, when we consider the child BO or the albumin-bilirubin ratio. So in clinical practice, based on what we have, the first treatment selection, when you consider that the survival improvement is your ultimate goal, you have 2 protocols. But remember, virus C and the response rate. And if this is not your primary goal and you need to stabilize your patient to achieve disease control, here we started to have the sorafenib, durva, and the monotherapy arm of durvalumab in the Himalaya trial. Definitely lenvatinib is there, and remember the viral etiology and the risky features. So how to prioritize your decision? For the EMBRAVE protocol, if no contraindication, no bleeding, or effectively controlled varices, you need rapid disease control and downsizing, and the etiology is hepatitis C infection to induce cirrhosis, and you have a careful team for managing the patient adverse events like hypertension and proteinuria. Go ahead to the EMBRAVE protocol. But if you have a contraindication for bevacizumab, you have risk to have bleeding and you cannot ablate it effectively with ligation or sclerotherapy, or the goal to have long-term durability in NASH, for example, not the viral etiology, you can go to durvalumab. And by the way, I think by the next years we are going to face HSCC mainly due to NASH or due to other metabolic syndromes. Beyond the first line, it depends on what you give in the first line. If you get started with immunotherapy, definitely you will go for the TKIs, while if you started with TKIs, still you have the leisure to go for immunotherapy in selected patient. This table, really, I am really impressed, because we are talking about malignancy. We are focusing on malignancy, but we are not much considering the liver performance. And the best assessment of liver performance nowadays is depending on the albumin-bilirubin ratio. We have 3 classes. For class 1, which is the best, and we do expect it to have more protracted survival, you can notice that the achievement is okay, but it's more pronounced in terms of hazard ratio for the atezo-beva. But if you have a patient with albumin-bilirubin ratio score stage 2 or 3, you started to have or to face the drama of compromised liver functions, and there is no benefit at all of going to any form of the treatment, whether immunotherapy or TKI. So patient with, based on this is a very recent publication in 2025, showing that no benefit at all, no survival benefit at all of starting any form of the treatment for patient with albumin-bilirubin stage score or stage 2 or 3. You are just accelerating the ultimate fatality of the disease, because this patient is going to die because of liver cell failure. And I do remember that I have read a meta-analysis including 11 million patients. It was a Chinese. The main reason of death amongst patients with HCC was liver cell failure, not the progressive malignant disease. This is what we have as an achievement for the survival improvement over the past 4 decades. For HCC, we achieved about 15% plus at the 5-year survival difference. And I'm going to stop here. Thank you very much for your kind attention. And I welcome for any question if you want. تفضل دكتور محمد.
Just I have 2 simple questions. The first one, the role of local control in advanced hepatocellular carcinoma, especially metastatic. يعني which patient او امتى حضرتك تبدا ان احنا نتدخل بتيس او اي local control رغم ان هو advanced stage metastatic systematic therapy. السؤال الثاني، لو انا عندي مريض received بيفا اتيزو.
طب نجاوب واحد واحد عشان انا راجل عجوز بنسى.
تحت امرك كده.
خليني بس على الاولاني. الأولاني local treatment when we have metastatic disease. I think we don't have any reason to go for local ablation except if this lesion, for example, is located subcapsular and causing pain or something like that, or the patient had shown unexpected response to the systemic treatment received. Here I can think maybe in the local treatment, but I should ensure first the super selectivity of tackling this lesion before doing anything, because I don't want to destroy the liver more and more.
Yes.
السؤال الثاني.
I read the paper I'm Brave 251. The patient who received atezo plus Biva and progressed, we can resume atezolizumab plus TKI like sorafenib or lenvatinib. Do you recommend giving this approach in our patients in our country?
بص، أنا من since the early days of the Embrave 150 I had a deep belief that if the study arm atezo-beva and the control arm was lenvatinib, we should have another result. It will not be that statistically significant to my mind, and it was confirmed in the LEAP-02. It was negative trial. Pembro Limva versus Limva, and it was stated clearly in this trial that lenvatinib was outperforming. Why? When you compare lenvatinib and sorafenib regarding the receptors ablated or blocked, they are identical except in one receptor or one pathway. For sorafenib it was the BRAF1, which is not that much accentuated amongst patients with HCC, while for lenvatinib it is not encountering or counteracting the BRAF pathway, but it's a potent FGFR receptor blocking, and this is very pronounced amongst patients with HCC. Because of this, you have seen the superiority in the response rate. It was nearly doubled comparing the lenvatinib and sorafenib. And the disease control, as you are talking about a late stage of the disease and this patient is not amenable for cure at any point, or even to think about the survival protraction. But the gold standard that once you have disease control, you can talk about survival prolongation, because you're going to keep your patient alive so far without progression. And on the same moment, you have to take care of the functions of the liver. To start with immuno plus TKI upon progression, I think it's a valid option, but we need data for this, because most of the trials addressing the second line, it was for the monotherapy, whether immuno or TKI. I think it will be the platform for neoadjuvant treatment before surgery.
I have a question. As we are trying to achieve compromisation between liver function with disease control. Your experience about giving the patient on and off treatment along the course of disease, if we have a slight elevation of the liver function with control of the alpha-fetoprotein or the disease size of the lesion, you can stop for a while till the normalization of the lung function and then resume it again.
Actually, there is no data for this, but in my practice, usually with lenvatinib, I am treating, then somewhat off, then to reinitiate again. Sometimes I got the same impressive first results of controlling the disease, and sometimes I am facing a heroic disease progression. So it's, I think it's a scenario patient by patient, not for the entire group. But if you stopped the treatment because of adverse events,
Mostly hyperbilirubinemia and
the patient with hyperbilirubinemia, I do believe that it will never go back to the normal events. I'm talking about the treatment-related adverse events, the hypertension, which is or thrombocytopenia or leukopenia, but not for the liver.
يعني I have 2 or 3 patients I guess بيحصل لهم elevation للبيليروبين level شويه يعني doubled or tripled وبعد كده الانترانس امينيزس نفس الكلام. When we stop الانفانتينب
You are lucky enough to find these patients يا احمد. يعني هم غالبا لما البيليروبين بيعلى هو خد الزحليقه خلاص. مش
بقى شوتينج يعني هو بيوصل ل 2 2.5 3 بوقف.
2.5 دي على فكره رقم مرعب.
I know بس لما بنديله ليفر فانكشن بيوقف 3 شهور علاج صحيح بيحصل نير نورماليزيشن بس بنلاقي الالفا بيتوبروتين بيرجع يليفيت تاني وهكذا.
بس لحقت ان انت ترجع له بعد 3 شهور يعني ما كانش Okay. Any other question? Thank you very much. دكتور.
Regarding the patient planned for immunotherapy and he's TB positive by gold test, is that a complete contraindication or a relative contraindication?
I think you have to treat TB first and don't treat both together because and yesterday, maybe 2 days ago, I have seen a patient with RCC and suspected to have active TB, and he was beautifully responding on the treatment of Pembro, Lenvima, and I am forced to stop the treatment. Although when we go to even to the Elsevier Golden Data Book, we didn't have a clear piece of information telling that we have drug-to-drug interaction between the anti-tuberculous drugs and the immunotherapy. But for me, so far I don't have this piece of information. I stopped the treatment and go ahead وربنا يتولاك برعايته يعني. I rest sure. اتفضل.
9 رأي حضرتك.
ما بلاش انا.
ليه ده بالعكس؟
لا اصل انا بص هو انا ليه بفكر في اميونو او ليه بفكر ان انا اغير في البلاتفورم بتاعي ان انا اشيل الاميونو ده واحط الاميونو ده. I think that Pembro and Nivo are counterpart to each other, and if I have some data making some preference to go for the checkmate family, it's an statistical numbers, not real life. I didn't see any difference between the Pembro and Nivo. وبما ان انا راجل عجوز برضه والبيمبرو نزل الاول فانا برو البيمبرو يعني مش برو النيفو خالص. الداتا are not convincing to me يا محمد. Is it convincing to you?
انا بس عشان العيانين اللي ساعات بيبقى فيهم contraindication زي ما حضرتك بتقول للبنت يعني.
I don't like the immuno by the way. I don't find it biologically rationalized because I am treating the same patient with immune tolerant liver. I have weapons and I don't have soldiers. What am I doing?
محمد
Thank you very much. هاني دكتور هاني.
تحب الكلام يا باشا؟
زي ما انتوا هو مش في بريك دلوقتي؟ 5 minutes بريك زي ما انتوا عايزين.